Hello, my name is Adelina Comas Herrera, and I'm very grateful to you for inviting me to join you today. And I will be talking about mortality associated with COVID-19 in care homes, looking at international evidence and then lessons for monitoring and surveillance. I work at the Care Policy and Evaluation Center at the London School of Economics. So first of all, I'd like to acknowledge my co-authors. A lot of the data I will present today comes from this report, which was co-authored by Jose Bazalacain, Elizabeth Lemon, David Henderson, Charles Litwin, Amy Tsu, Andrea Schmidt, Greg Carling, Florian Cruza, and Jose Luis Fernandez. And I'd also like to thank all my co-authors and contributors to LTC COVID, members of the International Long-Term Care Policy Network, and my colleagues at the Care Policy and Evaluation Center for all the work they have done that has informed this presentation. Any errors, omission, and views are my responsibility. So I'm going to start by looking at international data on COVID-related mortality in care homes and reflect on what it shows. And I need to also make sure to address that there are a lot of comparability issues with this data. In terms of the methods for gathering the data we'll share today, what we did was basically to search for official data sources on the numbers of people who lived in care homes who died as a result of COVID-19. The data checking and harvesting was done through also additional information that international experts through the LTCcovid.org website and the International Long-Term Care Policy Network contributed. This work has been an entirely voluntary activity. It wasn't funded, and it was done in addition to our usual day-to-day. So I'd really like to thank everybody who took the time to help and support this activity. The data from the different countries use different definitions and measures, and this means that we need to be very careful about how interpreted, because it might be that where we only observe small differences between countries, this is due to a difference in definition and not due to a difference on impact of, for example, the pandemic. So what did we find? In terms of COVID-19 related mortality among people who live in care homes, by the end of January 2021, we had collected data from 22 countries, and that shows that 41% of COVID-19 deaths were among care home residents. That is, of all the people who were dying from COVID in these 22 countries, 41% were people who lived in care homes. Now, some of these would have died in hospital, and some of these would have died in the care home itself. It's very important to compare this 41% with the fact that the population who live in care homes only represents about 0.75% of all the populations in those countries. And we know that even after accounting for the age and underlying health conditions of the people who live in care homes, it doesn't explain this magnitude of impact in this particular population. And there are some potential explanations as to why that is the case. The first one is the difficulty or even impossibility, one could say, of implementing physical distancing in care homes. Care homes were never designed to be isolation facilities. They are places of communal living. We also know that particularly in the first wave, there was late and insufficient access to testing for COVID and for personal protection equipment in most countries. We also know that it took quite a while for guidance issued to care homes to recognize the geriatric symptoms of COVID, for example, that some people, instead of showing the usual cough symptoms, might show delirium. And also, it took quite a long time for the guidance to recognize the possibility of asymptomatic transmission. In many countries as well, we know that people living in care homes will have had reduced access to healthcare, in some cases not accessing the help that they needed. And to illustrate the differences in access to healthcare in different countries, it's quite useful to look at this slide. In here, what we do is we compare the numbers of people who died from COVID who were care home residents, and this would be the people in the column in light blue. And then in dark blue, you have for the same country, the share of people who died in the care home. And the bigger the difference there is, then the smaller the bigger the difference there is, then the higher the share of care home residents who died from COVID died in hospital. So where the numbers are very similar, like in Sweden or in Wales in the UK, means that only a very small proportion of care home residents were admitted to hospital who had COVID. And you can contrast that with countries like Hong Kong, where all care home residents who had from COVID died in hospital, because the policy there was to transfer care home residents who had COVID straight to hospital and not even try to isolate them without the care home. So when we look at international data, it's very important to understand whether the data we're looking at is data on the total number of care home residents who died or the total number of deaths in care homes, because the differences can be very substantial. There have been ethical concerns about the degree to which countries have not transferred people to hospital when potentially something could have been done for them. And in some countries, particularly at the beginning of the pandemic, there were policies in practice where people weren't being taken to hospital just because they lived in a care home, or, for example, because they had the diagnosis of dementia. And there are important concerns about the human rights violations for this population, because you really need to base these decisions on the probability that an individual will be able to benefit from the transfer. In terms of the scale of the impact among the care home population, in this slide we show for a number of countries the share of all care home residents who have died linked to COVID-19. And what you can see is that in some countries, and the top you have South Korea, Singapore, New Zealand, Hong Kong, the share of care home residents who died is really, really close to zero. So the impact has been really quite small. Whereas at the bottom of the slide, you see countries like Belgium, Scotland, Slovenia, Spain, where a very large proportion of care home residents, around 8%, of all care home residents, have died due to COVID-19 or attributed to COVID-19. There's, in fact, quite a substantial number where about 1 in 20 care home residents have died, and that's an astonishing impact. Just to dig a bit more into what are the differences between countries and what explains them, the main factor, at least looking at national level data, appears to be the degree of transmission in the population. And the way we can look at that is by, if you look at this graph, you can see there's almost a perfect correlation between the two items of data. On the vertical, we have the deaths per 100 in care home population. On the horizontal axis, we have the deaths per 100,000 in the non-care home population. So these are the deaths of people who are living in the community. And you can see that the correlation is extraordinarily close to 1. And the reason for this is that basically we assume that it was really, really difficult with the measures that we had in place and the resources and the ability that we had in place to protect care homes when there was a high degree of community transmission of COVID. So we see that there's a cluster of the countries that had very slow transmission in the community, very small numbers of transmission. They also had very small numbers of deaths among the care home population. There are differences between the countries, but as I said before, we don't believe that the quality of the data and the differences of definitions make it viable at this stage to make comparisons between countries and try to relate the small differences we might see to the measures that were taken. So from looking at this international data, what have we learned? I mean, we started by looking at the share of all deaths that happens in care homes, and that's actually really useful to show the scale of the problem, but it's not that useful to tell us what the differences are internationally. And an example of that is that in New Zealand, quite a high share of deaths have happened in care homes, but we're talking a high share out of a very small number of deaths in total in the country. To compare the real impact in countries and be able to compare across, what's really useful to look at is the share of total care home residents who died, as this offers a different perspective on the differential impact of COVID-19 on care home residents. And as I mentioned before, the best explanation at the moment for country differences seems to be the overall levels of infection. And this suggests that the attempt to shield care home residents have not worked despite really strict and painful visiting bans. We also need to understand the other impacts of the pandemic on people who live in care homes, and particularly those with dementia, because there's increasing evidence that there's been a really negative impact on well-being, the mental health, the cognition and behavioral symptoms of people, particularly with dementia, living in care homes. And also we've seen evidence in some countries for increased prescriptions of antipsychotics. There's been some research at care home level looking at the factors that affect the risk of infections, outbreaks, and mortality in care homes. This is from a rapid review carried by McMaster University. And what they found, and this relates to what we saw at the international level, that the incident in the surrounding community is perhaps the factor with the strongest association for COVID-19 infections in long-term care settings. And this was also the factor for which there was the best evidence. They also found that there were resident level factors, and but here the quality of the evidence is lower, so it's low certainty. But they found some association with the racial and ethnic minority status of the residents, being older, being male, and being in receipt of Medicaid and Medicare, which is an American measure that tells us that people with the lower socioeconomic groups had higher risk. They also found that there was an association for severity of impairment of infections and outbreaks. They looked as well at organizational level factors, so things to do with the care home. And they found that having a high share of registered nursing staffing was associated with reduced risk of infections, outbreaks, and mortality. They also found that for-profit status and facility size and density were consistently associated with increased risk of infections, outbreaks, and mortality. It's really important, though, to note that many of these studies did not adjust for incidents in surrounding community, and also that some of the factors that were observed sometimes may have been correlated, and not all the studies were able to look at them separately. So there's a clear relationship between the for-profit status and facility size and density. And I am aware there's a systematic review that's just being published that looks at this in more detail. So to take a step back, why has all this happened, and why is it that we had so much mortality in care homes and that we haven't been able to protect better the people who lived in care homes? First of all, the biggest factor seems to have been, I'd say, a low political priority for long-term care compared to the acute healthcare and other policy areas. And this is partly explained because we have fragmented long-term care systems where the responsibilities are split between different government departments and levels of government. So you might have responsibilities at local, regional level. And basically what this meant is that no one was actually in charge in many countries for the response of the pandemic in long-term care. We also have seen many examples of failures in health and long-term care coordination resulted in people who lived in care homes having limited access to healthcare. We've seen weak regulatory oversight during the pandemic, so inspections were stopped, and there was very little support for care homes, and also inexistent or underdeveloped information systems that made it difficult to track the early impact of the pandemic, particularly, and in many countries, it's not really possible to know how many people have died. There's also been a lack of recognition of human rights of people living in care homes. I mentioned earlier the issues with transferring people to hospital who perhaps would have had an opportunity to survive if that had been done, but also the issues of visiting and accessing people to live with their to visit their relatives and to spend time with them. And I mean, imagine a husband and wife who may not have been able to see each other in some countries for almost a year now. We also are increasingly aware that a lot of the problems that we're observing are also linked to the under-recognition of care staff. The fact that in most countries, they have very low pay. There are already existing staff shortages that may have been aggravated during the pandemic, and that there are very poor working conditions. And to give you a specific example, in many countries, people working in care homes don't have sick pay. And that meant that if they had COVID themselves or potentially had COVID, they had to choose between going into their work and then spread the disease, or stay at home and not get paid. And for people who are already in very low incomes, this is a really, really difficult and painful decision to have to make. So how do we deal with the current situation? At the moment, it's very clear, and I think it's very well recognized how important it is to vaccinate people in care homes. But following from that, it's urgent to resolve care home visiting restrictions, given the huge well-being impacts. And of course, vaccination should hopefully make these decisions earlier to make for policymakers. Many countries have adopted good measures to try to protect care homes that are consistent also with the recommendations of the World Health Organization, but the implementation still remains a challenge, and it's important to make sure that the care homes continue to have access to testing, that the results are available quickly, that we address the issues of the cost of PPE and who bears the additional cost of the infection control measures, making sure that care homes that don't have adequate space to implement isolation have options to deal with this, to understand well the particularly difficulties of isolating people living with dementia, and make sure that we understand how to get sustainable recruitment for staff working in this sector. And I'm going to end with some thoughts on the future of long-term care after COVID. And it appears that we have an opportunity to learn and build and make sure that we make the most of the public and political attention to long-term care. It is a chance perhaps to try to address some of these long-standing structural problems that in many countries include addressing the issue of financing. At the same time, though, we know that it's going to be challenging because we expect many countries to have higher public deficits that may reduce the scope for increased public spending. The emerging picture of the responses that we can observe in different countries seems to be that there is a lot of thinking about whether it's possible to reduce the reliance on care homes by increasing the capacity in community care and increase support for unpaid carers. There seems to be some evidence that there's an appreciation of smaller care settings that are more strongly linked to the community, and we might see some changes in the future models of care. And I think you're going to be discussing this later today. And I'd like to make here the comparison. So are we talking about homes with care or care homes? And can we move to a less institutionalized approach to care homes? And finally, I think we have an opportunity to clarify the role of care homes. Are we wanting to talk about long-term homes where care is provided? Do we talk about intermediate rehabilitation care settings that support the healthcare sector in post-discharge? Or are we talking about palliative care settings? Because these are very different settings that try to support different populations and have very different requirements. And at the moment, in many countries, what we have is a care sector of one size fits all. Thank you very much.